Got clients that are sitting like this a lot on their text or laptop. Hey there, this is Dr. Evan Osar. No phone here because the phone is recording this Facebook Live. This is take 2 since I recorded the first one with no volume. So thank you for those of you that sat through the first one with no volume. And my buddy Pete out in New Jersey, my best friend, he was like, yeah, there's no volume. And I'm like, it's because he didn't turn on the mic. All right, so here we go. So in this edition of Facebook Live, thank you again for joining me this morning. And thank you for being part of our community, allowing us to share this information. We're going to discuss 3 things, and I'm going to go a bit quicker this time since this is the second take. Maybe it'll be better. I don't know. We'll see. So one of the things that a lot of our female clients have is pelvic pain, especially back on the back side here, around the sacrum, sacroiliac joints, and or tailbone. Now, men have this issue too. So like, for example, like when I'm on a plane for any time longer than 2 hours, my tailbone is always sore when I get up. And in fact, the longer the flight is, the more sore it is. Now, I'm someone that has never had low back pain, never, knock on wood, never been out because of low back pain. It's never stopped me from working out or doing anything. And I still have issues with those plane seats. Now, we can recreate a lot of, we all know that those plane seats are awful. However, we do a lot of the same things in our regular chairs. And one of the things that we generally will do, our clients will generally do, is they'll roll back into excessive posterior pelvic rotation, and that puts their weight directly on their sacrum and especially their coccyx. So it overstretches those ligaments, the sacrococcygeal ligaments, the sacroiliac joint ligaments, and the fascia that's on the backside of the pelvis, connecting to the glutes, through the SI joints, through the pelvis, and into the low back. Now, for some of our clients, that doesn't really make a big difference in their lives or their bodies, but for many of our clients, especially women that have ligament laxity, true ligament laxity, or around the time of their menstrual cycle where they have a bit more ligament laxity, or women that have had maybe overstretched ligaments because of childbirth or some other kind of trauma, this can be a big issue for them. So this also leads into exercise as well, so we'll demonstrate an exercise that this concept relates to as well. One of the things we teach our clients, especially women that have pelvic pain, SI joint pains, coccyx pain, we're always going to work with a pelvic floor therapist, or frequently, I should say, we work with a pelvic floor therapist, and for a lot of our female clients that have had children and or some kind of, reproductive organ sort of issue and or surgery, we almost always send them to a pelvic floor therapist. And the reason why is because they can do internal exams, they can look at ultrasound to see how the muscles around the abdominal wall, the pelvic floor are working, and they're much more qualified to do that than I can. Obviously, I'm going to work within my scope of practice and feel the muscles around the hip joint, feel the muscles and the connective tissue, and evaluate the SI joint, the coccyx, and the sacrum from an external standpoint, but I can't do that internal exam, and nor do I want to determine what these pelvic floor muscles are doing, as well as some of these other areas. So again, work with a qualified therapist, because then you can take that information, give it to your client, or your client already has it, they give it to you, but you have this collaboration with someone who has a specialty that can benefit everything that you're doing from a corrective exercise and functional training standpoint. So one of the things we always train our clients, our female clients, to do is get onto their sit bones. They're called the sit bones. These ischial tuberosities are referred to as the sit bones because these are the bones that you should sit on. We should be sitting on. That's why they're really the thickest part, almost the thickest part of the pelvis. The pelvis is quite thin up here. It's quite thin around the pubic ramus here, but around the ischial tuberosity is quite thick because, again, you have your hamstrings coming up and attaching into the ischial tuberosities, so a lot of tension there, but these are the bones that you should be sitting on if you're sitting on a chair. So we want our clients to learn how to sit on their ischial tuberosities, because a lot of our clients are in posterior pelvic rotated position. Because again, a lot of our clients are standing like this, living their lives like this, or they may just be overstretched from, again, life, surgery, things like that, pregnancy. So we want our clients to learn how to anteriorly rotate so they can position their ischial tuberosity underneath them. So the first thing we teach them is not to drive their hips back in the chair, but to rotate. Very different motion. Anterior rotation, if you notice, allows my pelvis to go back. But if I'm in posterior pelvic rotation here, I can push my hips back and never get out of posterior pelvic rotation. And that's what happens for a lot of our female clients. So they end up sitting on their tailbone, and hence discomfort around the area and or sacroiliac joint issues and or low back issues. So we want our clients to first anteriorly rotate so they can get their weight onto their sit bones and then bring their body over top. And now the head, neck, shoulder, trunk is aligned over top the ischial tuberosities where it should be. So the question also often comes up, well, Dr. Osar, that's very rigid posture, and clients can't stay like that, and you're actually creating more rigidity by doing that. I would agree if a client stayed like this all day long and this is all they did and never moved out of it. But we never teach our clients to do that. We teach them to get up frequently. We teach them to do some squats, some wall planks, some breathing, some just walk around, sit back down. Because inevitably, we're all going to, no matter how well we sit up, we're going to rotate more and more into posterior tilt. We're going to end up like this no matter how hard we try. So one thing we teach our clients is sit on the edge of the chair, sit on your ischial tuberosities, do your work. Sooner or later, you're going to get like this, or you'll lean over, or you'll cross your leg, or you'll do one of these things, or you're looking over there as you're working. We're all going to get into those positions. And that's okay as long as we're not continually going back and staying in those suboptimal sort of positions that are leading us to, or leading our client to overstretching and or stressing those areas. So take home lesson here. Teach your client how to do anterior rotation of their pelvis, sit on the sit bones. Encourage them, get out of their chair a lot and move around. They can stand up and just do some mobility. They can reach, they can do some different reaches and just mobilize their pelvis, but get them sitting down on their ischial tuberosities. Now, second point is that also leads into deadlift patterns, because again, it's a very similar concept when we're teaching our female clients to deadlift. And we do teach our clients to deadlift because the deadlift pattern is a functional pattern for everyday life. If you need to get a bag of cat food off the floor, or cat litter, or groceries, that's basically a squat and or deadlift type motion, because it helps to load the posterior hip complex, load the posterior chain, and takes the stress off the low back. So we have to deadlift. We want our clients to deadlift. It will also be a part of increasing bone density, because again, you're loading the spine. Not everybody can do a barbell deadlift, nor do they need to do a barbell deadlift, but they should do some version of the deadlift pattern. Now, when we teach our clients to do deadlifts, it's the same concept. I just did a post this morning about 2 different ways to deadlift. Very similar pattern, same pattern, however, for 2 different strategies. Now, the one strategy, and then one of the conversations and sort of discussions that our industry has, I should say, it's not a discussion that they try to argue that they're right, is, I discuss how we should teach our clients to go anterior, as far as anterior rotation, as far as they can, because this minimizes the spinal loading. Doesn't reduce it, completely eliminate it, I should say, but it does reduce it, because if I anteriorly rotate as far as I can, my spine is going to be relatively well protected here in its best neutral position. Now, yes, the pelvis is going into posterior pelvic rotation slightly. The spine is flexing slightly. I wrote about this in the Exercise Solutions several years ago when I wrote that book. I discussed all about the motions of the pelvis and lumbar spine. What we don't want our clients to do, and what happens for a lot of our clients, especially clients that hang out in posterior pelvic rotation or hang out in that anterior sway position, which is not anterior pelvic rotation, it's just anterior sway. What happens for a lot of these clients is they go very rapidly and significantly into posterior pelvic rotation, and now that stress comes out of their, I should say, is reduced in their glutes and hamstrings, because these areas are no longer eccentrically lengthening, and they're starting to eccentrically lengthen and load their lumbar spine. That's the problem, is you're transferring the load where it should be from the glutes and hamstrings to the low back once you lose that ability to anteriorly rotate, or you go too far into posterior rotation. So the most important thing we want to teach our clients is how to anteriorly rotate their pelvis and their entire cylinder. So it's not just the pelvis going anterior, it's a whole cylinder that goes anterior. So a great way to determine your client's range is just have them put their hands on their pelvis. I'll feel this on my client, because I can put my hands on my client, but if you can't, just have them put their own hands on their client. Put their own hands on themselves, and then rotate as far as they can. You watch their hands. And right about here is where I should stop. Because if I go any further, boom, posterior pelvic tilt, lumbar spine flexion, too fast, too much. It's not a good position for me to load my spine. Check out our Instagram page today. I just posted a video talking about this very subject, the difference between limiting range of motion and not limiting range of motion, and what impact that has on hip rotation. I did the video and posted it just this morning. So for me, I will go here, and that's where my spine is the best protected, and I can best eccentrically load my hamstrings and glutes. I could pull from the floor, but this is not a great position for me to load from and to pull from. So for me, doing an elevated supported, I should say a rack supported deadlift is a much better position. For a lot of our female clients, it's about limiting their range of motion so that they can really focus on the glutes and hamstrings and then focus on that pull. So set them up, align the head and neck, thoracolpelvic cylinder, hinge, grab the bar, get up close to it, and then it's a pull, drive up, not forward, because that's the other thing you'll see me do in the video today. Doesn't feel good on my back. It's not good biomechanics either. So control the eccentric. So from here, it should be the same position as you saw me back here. So here, boom, up. Everything's contracted, stable, controlled, not here. Everything's lined up over top of my feet, and now control the eccentric. And again, if your clients can't do barbell squats, you don't have a barbell, no problem. Medicine ball works just as well. You can have your client basically just come down, boom, bring it back up, down, bring it back up. So again, you're still teaching them the same mechanics. It's just a different implement for loading the spine. You can load it with medicine ball, dumbbells, kettlebells. You can use band resistance or cable resistance. You can even, it's basically the same pattern here. It's the same pattern using a cable resistance. Same idea. It's that same anterior rotation, same control, then boom, come out back up without over squeezing, over contracting, or changing that alignment. So excellent patterns to train your client for everyday life. Train your clients for bone density. Train your clients to reduce a lot of that stress that comes from living, loading, and being in posterior pelvic tilt for a big portion of their day. And you'll help a lot of clients, a lot of your female clients, after pregnancy, before pregnancy, help them get ready for pregnancy. Help them increase bone density, as I mentioned, muscle mass, addressing sarcopenia, which is a big issue. My buddy Robert Linkle talks a lot about that. We have to help our clients get stronger, increase bone density, and also address some of the issues that keep them from being able to exercise and do the things that they need to, want to, and love to do. And that's how you become an expert, a go-to expert for your clients, and attract more individuals that need, want, and will pay you for what you do. So in this brand new series of Two Anatomy Geeks, we're covering, my friend Jill and I, my colleague, my fellow anatomy geek, Jill and I are covering training the female client. Week one, we're going to discuss training the pelvic floor, specific pelvic floor and hip mobility, and how the pelvic floor and hips work hand in hand, and how pelvic position, as we just talked about today, is so important for sitting, for loading, and for reducing a lot of stress on the low back. On week two, we'll discuss more of the menstrual cycle and what happens around the menstrual cycle, as well as some of the issues associated with pregnancy and surgery, especially surgery like C-sections. My friend Jana, our colleague Jana, integrative movement specialist, just shared I've known her for years. She came through our certification program, and I just learned her personal story about life after a C-section and how she was told to go back to exercise, wasn't really giving much instructions, and then she burst through her C-section scars, and she had been dealing with issues around that as well. So a lot of our women are having C-sections. I believe I think my wife was saying, like easily 1 million and maybe even more than that of women every single year are having C-sections to deliver their children. Some of them absolutely need it, right? But we need to help or educate these women about what to do with their abdominal wall, their pelvic floor, and get their body back after C-sections and or natural childbirth, because a lot of women are having childbirth issues or damage and then never getting the appropriate care until they start having other type of issues. Then in week three, we'll talk about all things bone density. I'm going to bring in my nutritionist, my personal nutritionist and friend, Sherry Belcher. She's who we refer all our clients here in our office to discuss some of the nutritional aspects of it. That's a little bonus interview we're going to throw in there. I did a bonus interview with my good friend and colleague, Dr. Nidhi Sharma. She is a pelvic floor therapist. She gave us some great information and things to think about as well. And then we'll provide you with, obviously, some strategies for increasing bone density, things you want to think about, things you want to avoid, and we'll talk all things osteoporosis in part 3. So I hope you join us. It's a great way, it's a great environment. It's a really positive, proactive environment with people. They're just looking to learn and support each other. We have a lot of fun sharing this information, and people really enjoy, our community members really love this this community and learning in this manner, because we want to make sure that you're able to take this information home to your clients and use it right away. So it's not just, theory like, okay, this is cool information to have, but it doesn't help me. No, we give you an application that you can go home, use right away with your clients. So we look forward to seeing you. Two Anatomy Geeks. The link is next to this video if you're watching it here on Facebook or on YouTube. Join our YouTube channel. We send out every single week. We send out educational videos like this to help support you and help you serve your clients. So thank you again for allowing me to be part of your community, allowing us to be part of your community, and for all you do for your community. If we can help you in any way, please let us know. And we look forward to seeing you on Two Anatomy Geeks a week from Saturday. Make it a great day. Get out there, lead, and be that light for your clients. And we'll look forward to seeing you next time at Integrative Movement Insider. This is Dr. Evan Osar. Make it a great day. We'll see you next time.